why don't we go ahead and kick things off? Thanks everyone for joining us. And for those of you joining us for the first time, my name is Eric Zimmerman. I'm a director at Hadaway Communications, and along with my colleagues, we serve as the Secretariat for the STAT Communications community. This community, as many of you know, grew out of the work of the State and Territory Alliance for Testing, a group of more than 30 states and territories now convened by the Rockefeller Foundation, who gather regularly to share insights, success stories, and lessons learned on all aspects of the pandemic response. An important part of that work is communications. What's been working? What have we learned? When and how do we need to adjust? And answering those questions is the goal of this community and the goal of each of these webinars in a slightly different way. In many of our past webinars, we've talked quite a bit about the fine line between vaccine competence and vaccine access. If someone is on the fence about getting the vaccine, or if they want to get the vaccine but just haven't gotten around to it yet, the difference in their decision may be how convenient it is, how easy or difficult it is to make an appointment, whether it's at a location that's convenient for them, and whether it's staffed and supported by people that they trust. So just as there is a fine line between confidence and access, there's an equally fine line between a communication strategy and an outreach strategy. We need to reach people where they are in a hyperlocal way. We need to address concerns specific to them, and we need to do everything we can to bring vaccines and the vaccination experience right to their door. So today, we're going to focus on the intersection of communications and outreach with Molly Chidester and Charlotte Weiner from Stop the Spread, as well as Chris Nicholson from Impulse Mobile. Stop the Spread catalyzes the private sector to fill gaps between the government's response to the pandemic and a community's specific needs. They're going to share lessons from their work implementing vaccination strategies in hard-hit neighborhoods in New York City, where they bring community outreach and operations together to increase vaccine access, raise awareness, and build trust with the community. Impulse Mobile has been their digital outreach partner in this effort. So Impulse is a conversational AI platform that supports better health outcomes by using behavioral science and analytics to match users with tailored content specific to their health needs and concerns. So Chris Nicholson will be sharing how they've used this platform in partnership with Stop the Spread's hyperlocal approach. And before we get started, I just want to say our format today will be slightly different than in past sessions. We'll be breaking this session into 3 short modules and pausing for Q&A along the way. So first, Stop the Spread is going to share lessons from their work in New York City, focusing on the relationship between awareness, access, and trust. Second, Chris will be sharing their digital outreach work. And finally, Molly and Charlotte will be discussing Stop the Spread's Vaccine Plus program, which connects people to healthcare and social services as part of the vaccination experience. That's all to say, as you think of questions along the way, please don't save them for the end. Just put them in the chat or the Q&A box as we go, because we'll be stopping periodically to answer them. Okay, so without further ado, I'm going to turn it over to Molly and Charlotte from Stop the Spread.
Great. Well, thanks so much, Eric. We're excited to be having this conversation today. We really think this is one of the most important conversations we can be having as the country reaches this tipping point between our supply and demand, where we're now seeing that our supply actually outweighs demand. You gave us such a nice introduction to Stop the Spread. I'll give a little bit more insight into how we're doing our work, but as Eric mentioned, we are a COVID nonprofit organization that was set up in March a year ago to catalyze the private sector in response to the pandemic, absent a national response at the time. Initially, we were very focused on PPE, testing, ventilators, finding novel solutions to fill critical needs. And over time, as the needs of the pandemic have evolved, our focus has really shifted from capacity building to the equitable deployment of solutions to communities that were being hit the hardest. We started as an all-volunteer organization, not expecting to need to be around a year later, but here we are in May 2021. We are now a part of Impact Assets, an impact investing firm. We have a board of industry leaders, epidemiologists, technical and community advisors that we work with. And our approach has really been about bringing the public and private sector together through philanthropic funding to deploy hyperlocal strategies, and then to share what's working nationally. We help community organizations and our private sector partners step outside of their traditional boundaries and comfort zones and work together in partnership to collectively drive COVID response. We've built a network of a combined over 700 and growing partners now. You can find out more about them in our website. And today we're going to talk specifically about our work in vaccines. Our efforts have been focused really explicitly on communities that have been historically underserved, communities that have seen higher rates of transmission, of hospitalizations, and of deaths. And we're also using this moment, as Eric mentioned, to think about ways that we can bring other resources to those communities, whether they are healthcare or social service supports, through a program called Vaccine Plus, which we'll talk about in a little bit. We're at this moment, as I think everyone on this call knows, that things are only getting harder in terms of vaccine dissemination, especially as we're at this tipping point. What you'll see on the slide here, I'd say these are national trends, but what we wanted to highlight, because we're going to focus on our work in New York, is what we're seeing on the left-hand side of this graph, which as of April 1st, we have seen a significant drop-off in vaccine uptake. And unsurprisingly, on the right-hand side, what you'll see is that where we have seen people getting their first doses are some of the more affluent parts of the 5 boroughs of New York. So as a Politico headline recently read, now comes the hard part, and that's what we want to talk about today. So how do we address this? Well, we're really encouraged at Stop the Spread that we're seeing a shift across the country from vaccine models that have historically focused on speed, mass vaccination sites, drive-in vaccine clinics, vaccinating thousands of people per day, to a new focus on models that aim to achieve equity. These are small dose strategies through very targeted community-based and pop-up sites, which is what we want to share with you. And this is the work that we've been doing in New York since January of this year. And we're excited to share what we're seeing on the ground that's working. The first and really important point on this is that building a vaccine site in a neighborhood with low vaccination rates is not enough. As we saw earlier this year in some of the headlines, accessibility is about much more than location. When vaccine sites went up in hard-hit neighborhoods in Oakland, California, in Manhattan, floods of people from other neighborhoods came in to get vaccines. And so to ensure that vaccines reach those that they are intended for, we've identified 3 critical elements that we're focused on at Stop the Spread. And we see all of these pieces working together in what we call a flywheel. So the first piece is on access. This is really about purpose-built access for the community that it intends to serve, co-designed with the community. Trust that is established by working with community partners to build vaccine competence, and awareness or information sharing through community and private sector partners like MPulse. An example of this is an event that we're planning to celebrate Pride Month next month, where we'll be putting pop-up clinics in parks in the borough of Queens in New York City. These pop-up clinics will be led and directed by members of the transgender program at one of the FQHC partners that we work with. Community partners will be a part of our outreach strategy through word of mouth, as will tools like MPulse, to invite members of the transgender community to join us for a day of barbecues and vaccines and celebrate Pride. We believe that this final mile will require a new level of cross-sector partnerships powered by anchor healthcare organizations, community and faith-based organizations, as well as private and philanthropic sector partners. And so with that, I'm going to hand it over to my colleague, Charlotte, who leads our community engagement work at Stop the Spread and is doing much of this on the ground in New York.
Awesome, thanks, Molly. So I'm excited to share more about our work with Community Healthcare Network. Just to share a little bit of background, in January, Stop the Spread started working with Community Healthcare Network, which is one of the largest federally qualified healthcare centers in New York City. CHN serves 55,000 patients a year out of their 14 health centers across the city. And this winter, they had actually started distributing vaccines out of their own CHN clinics. But almost immediately, they realized that they were going to have to get vaccines further out into New York City's hardest hit neighborhoods to really make a meaningful impact on health equity. And that is where our work together with them began nearly, it's a little hard to believe, but nearly 6 months ago. And through our partnership with CHN, we've now distributed over 15,000 doses through pop-ups and through fixed community sites across the city. So I want to start by sharing some quick key insights from our pop-ups and fixed sites themselves, starting with pop-ups, which I know has been sort of a lot, quite in the news and is really, really core to the work that we're doing in New York. For pop-ups, we believe that we've identified a real replicable model that brings together a healthcare anchor like CHN and community partners. And the key idea here, and something that we think about a lot, is we are not creating any new coalition or asking folks to fundamentally build anything new. Really what we're doing is we're bringing together existing trusted CBOs to do what they do best. So as you'll see on this page, what this really looks like on the ground is we have two players. We have the healthcare anchor, and then we have the community partner. The healthcare anchor, which in our case is CHN, for these pop-ups, they bring the vaccines to the pop-up and they bring the clinical staff. And then the community partner provides space and they provide outreach to community members. They are responsible for bringing folks to the event and being the trusted messengers that provide the space and get folks to show up. On these pop-ups, we're partnering with organizations like the Salvation Army to do food distribution alongside vaccinations to the folks that the Salvation Army serves every day. A pop-up that I feel especially excited about is we're partnering with Tominac Houses, which is a New York City housing development in Queens, where only 2% of the 4,000 folks who live in the housing development have gotten vaccinated. And I feel lucky I get to spend part of my weeks having the conversations with the CBO partners and folks on the ground who are interested in working with CHN on the pop-ups, and just the, head of the Residents Association at Tominac Houses who came to us and said, okay, only 2% of these 4,000 folks have gotten vaccinated, but if we could have a pop-up right here in Tominac Houses, hundreds of people would show up because they trust me and I'll be running the site. So that's a little bit about our pop-up work. The second model that we've pursued with CHN to get vaccines out into New York neighborhoods are fixed sites. So in New York City, what this looks like is 4 permanent sites in churches in hard-hit neighborhoods across the city that we launched in late March and early April. I think the main point we want to talk about in terms of these sites, at least to start, is that these sites are really designed to be for the whole neighborhood. As I will describe more later, we are literally going door to door, putting up flyers in the neighborhood, and using these sites to do everything that we can to get the surrounding neighborhood vaccinated. One just quick story I want to share here is, story about one of the folks at CHN who said that when they were doing outreach for one of these sites, he literally went over to a hair salon nearby and started a conversation with one of the hairdressers there. And it turned out one of the reasons she hadn't gotten vaccinated is because her only breaks during the day are the 45 minutes when the client that she's working with is getting their hair dried. And the person from CHN literally said, I promise you, if you come with me, go over to get vaccinated now. If you want to, you can come over and get vaccinated, walk right over, come back, you'll be back in 45 minutes. And she had just put someone in to start getting their hair dried. And she said, sure, I'd love to do it. And she went and got vaccinated and came back in 45 minutes. And so that's the kind of conversation that we're able to have, and the kind of community resource that we want these fixed sites to be. So now I've shared just a little bit of an overview of the 2 kinds of work that we've done in New York. I want to really shift the focus of the presentation onto 5 approaches that have worked really well to drive that access, awareness, and trust flywheel that Molly gave the initial voiceover of. Just for a preview, I'm going to voice over the first 2 approaches, and then I'm going to pause for questions. As mentioned, we'd love to hear any questions or thoughts you all have. And then I'm going to hand it over to my co-presenter, Chris, from Impulse to talk about digital experience. And then Molly and I will speak to the final two drivers, including Vaccine Plus. So the first of the 5 takeaways that we want to share more about is just how critical it is to make a flexible scheduling system. Overall, we are a really, really big believer in walk-ins. We pushed in as quickly as possible. We opened up all of our sites to walk-ins, both the fixed sites and the pop-ups. But we want to also call out here is we've had a lot of success figuring out how to prioritize appointments that are carved out for the community. So the way that we think about this, I will talk about 3 points. The first is that we created a priority access scheduling system where we created our own one-click scheduling tool where we could reserve spots for families and friends that wanted to get vaccinated, for churches that wanted to bring in their whole congregation to our sites, and for neighborhood groups to get folks to sign up. A second point beyond simply creating the mechanics to enable that real flexible scheduling system and access are really, really important to us. A second point was we are working from the start on reaching out to folks who didn't feel comfortable scheduling appointments for themselves, but also really wanted an appointment and didn't want to just, rely on what some folks perceive as like the uncertainty of walk-ins. So we worked really closely with a volunteer group called Epicenter, which is a volunteer organization in Jackson Heights, to train them to do their work, which they do every day, of getting folks signed up for vaccinations, train them to use our scheduling system to get folks in the neighborhood signed up for the sites, which Epicenter was really excited about, and we were excited about too. Finally, we know that like a scheduling system that's purely online does nothing to address the digital divide. And so we also, created a multilingual callback team to schedule community members who wanted to get appointments over the phone. The second learning that I wanted to share before pausing for questions or reactions or thoughts is on the ground outreach. On the ground outreach has been essential to our work from the start in New York. And I think of this quote, which one of the community partners from Manhattan told me last month, this idea that the expectation can't be that folks come to us, we have to go out to them. And we think of this community outreach work happening in concentric circles at every moment that we're doing this work to get vaccines out into the community in New York. And really at the center of these concentric circles are the site directors, the folks who run the 4 CHN sites in neighborhoods across the city. These site directors who run the vaccination sites in churches are CHN staff and community organizers who have been working in these communities for years. They each have built out on-the-ground outreach teams, which are a combination of folks from CHN who know the community really well and are community outreach sort of folks themselves, and then parishioners from the church sites to actually be on those outreach teams and do outreach in their own community. So the quick example I want to share here is from the work in Washington Heights. You'll see the map over on the right-hand side, which Harvey, the site director, created with his team. And they literally broke the neighborhood down block by block. And starting with section 1, which they're working on right now, they're going door to door. And they are doing announcements over intercoms in grocery stores. This past weekend, they tabled at a local health fair, and they're posting up at subway stations, and they're working through the existing partners at the church to get the word out. I was on a call with the Fort Washington, Fort Washington is our site in sort of Upper Manhattan, on a call with the Fort Washington outreach team, figuring out which local bodegas in the neighborhood they want to prioritize for outreach this weekend. So before I pause for questions or any comments, I just want to say, we want to underline how much we believe that this on-the-ground outreach work needs to be a part of how we think about community health. It has taken a pandemic for us to reach out to community members where they are and to transition from this expectation that people come to us to the understanding that we have to go to them. And that insight for operations and communications is something that we think is really, really critical. So I will pause there, and I would love to hear any questions or reactions from the group before we transition to Chris on digital outreach.
Charlotte and Molly, thanks so much. It occurs to me that what you're doing on the ground, and one of the reasons we were so excited about sharing this content, is essentially audience research in real time, and adjusting on the fly to make sure that those specific barriers are being addressed and overcome. One question that I had is, as you try to balance the walk-in approach versus the scheduling approach, what implications, if any, have you seen about equity when it's open to whomever without an appointment versus trying to set aside priority scheduling and knowing some of the logistical challenges that may come with that along the way?
I think we've both kind of seen this play out in New York, so it's a great question. Charlotte talked a little bit about the scheduling system we created, where we're able to really carve out and allocate slots and appointments to churches, to CBOs that want to get their clients or members of their congregation in. We've seen in these sites that when that is opened up to the rest of the city, there is a very stark contrast in the people who are coming in to the sites, and really shifting from members of the community to people Ubering in from, frankly, other parts of the city or outside of the boroughs. So we've definitely seen that play out. I do think that what's been key to the walk-in approach and making sure that that doesn't happen there is really the outreach that Charlotte talked about, and like raising awareness that these sites exist by going door to door in the community. Charlotte, I don't know if you'd add anything else to that from your perspective.
Yeah, I think I completely agree with all that. And I think the only thing that we'll add is, as obviously we've seen the real drop in demand over the last couple of weeks that Molly laid out, even before we saw that, we were pushing for walk-ins. But now that the core of so much of the work that we're doing is this outreach work, having walk-ins is just proven essential. And we'll talk about a little bit later on the power of just word of mouth in these communities, that being able to tell literally, like, the teams at these sites are amazing, and when someone gets in to get vaccinated, they're telling every single person, like, when you come back for your second dose in a couple of weeks, bring a friend, or if you go back and if anyone else needs to get vaccinated, come by, we're not turning anyone away. So I think having the ability to do walk-ins is essential. We are very worried about it at the start operationally. It's just a lot more complicated, but it is more than worth it to figure out the operational back end to be able to open up all the sites for walk-ins.
And Jim has a question here in the chat, which is that, we've heard multiple touch points of communication is important on vaccines. Is there anything you're doing to track participants that you're in contact with, or is that not cost effective possible?
I guess I'd be curious to know a little bit more about sort of what the question around tracking specifically. And I will say that we are, picking up the phone and calling, emailing, really in touch person to person with the people who are coming into these sites, to the point that when they say, I have, 3 family members I want to bring with me, I want to make sure that all 3 of us can get a slot at the same time, we're actually able to accommodate that because of the person-to-person outreach. I think part of this will be answered a little bit as we use technology and tools like mPulse, and we're really going to be able to tie outreach very clearly to someone's decision to come into a site. I think Chris will talk a little bit more about how his team is able to do that, and we're working together.
And the last question, I think, before we move on, is I'm curious the degree to which the CBOs or the members of your team doing direct outreach have any type of kind of communications guidance or playbook that they are sticking to, or whether they have sort of free reign to follow the conversation based on each individual's perspective, concerns, so on and so forth.
Yeah, I can hop in briefly here, and then Molly or Chris, a few other thoughts. The communication that works in each neighborhood is quite different, and it's been remarkable to even see within New York the diversity that we know exists in 181st Street, where one of our sites is, versus 145th Street, versus East New York versus South Jamaica. Each one of the site directors has worked in the neighborhood for a really, really long time and has their own approaches for what'll work in terms of communications, whether that's like going door to door, like we need to get on this specific radio station, like that is the best way to reach this specific community. So I will say they are figuring out as they go, and they've had a lot of work with this. I think this point of one of the objectives of our work is to think about what are the learnings. Like there are people across the country figuring out what it looks like to do good on the ground communication right now. And it's been a process of these teams have been on the ground figuring this out day by day. And they are like so smart and so amazing and doing incredible work on community outreach. And it is also a process of all across the country, folks are figuring out to do this right now. And so I think where there are opportunities to be sharing best practices across all of the groups across the country that are doing this work in parallel, we feel really energized by that. And that's part of our work at Stop the Spread, is bringing resources to these site directors to give them support. But it is critical, and I think it is something that has been sort of under researched, underappreciated. But Chris and Molly, if you hop in, I'd love to hear your thoughts too.
Yeah, this is Chris. I've actually got a slide I can tee up in just a minute that talks about some of the feedback and the way, that we're seeing it. And I think the piece that you mentioned, Charlotte, is about the local nature. And I think that's what we're really seeing. And then having to tune and tailor the dialogues based on what we are learning about in certain, markets, based on, different access points, timeliness, certain socioeconomic factors that are really impacting people's ability to get scheduled or to coordinate. And so that's where, being as relevant as we can and as real time as we can in those communications becomes really valuable, because we need to get that data back to the frontline, workers, so they understand that there's actually, a perceived challenge or barrier that is existing that's actually limiting people from scheduling when there may not really be one, right? But we need to tackle those perceptions really quickly.
Yeah. All right, well, that sounds like a good transition to move over to Chris, your portion of the presentation. So I'll let Charlotte unshare her screen.
Yeah, I can very quickly, and then I'll hand over the presentation to Chris. But I just wanted to give Chris the introduction he deserves. So I think just to really quickly tee it up before I hand it over to you, Chris. When we are doing this door-to-door outreach, as we described, and making these sites as accessible as possible, we know that this whole country is on a spectrum of readiness to get vaccinated. And we know that every person's decision is really personal. There's new data coming out every day on this. And I know, Chris, you're going to share a little more, sort of double click on this data as well. But the question that data like this prompts on willingness and the number of Americans that have yet to get vaccinated is how to reach folks across the spectrum. So I'll hand it over to you in a moment, Chris, but it's like really, really to answer this question, we believe that working together with Impulse, which is using personalized behavioral data science informed approaches that meet community members where they are on that willingness spectrum, and when they're ready, directly connects them to one of our vaccination sites on the ground, is just essential. So we believe so deeply at Stop the Spread in the work of bringing together public and private sector partners. And we are just feel so lucky to be working with Impulse. So Chris, I will stop sharing my screen and hand it over to you.
All right, wonderful. Well, and thanks for the great introduction too. And it's been a great partnership, and I think it's exciting to see how these things come together, honestly, and really just to see how Stop the Spread has evolved over the last year. And so that piece has been really exciting for us as we've been partnering and just seeing the impact. What I want to talk about, quickly is, I'll jump into the digital engagement space. I'll talk about conversational AI and some of the behavioral data science and some of those elements, but really trying to bring it back to sort of understanding, the consumers that we're engaging with. And I think is, Charlotte and Molly were talking about all the different sort of services and capabilities, coming back to this piece around, again, uncovering the barriers through conversation and dialogue. And so when we talk about conversational AI, it's really just a strategy to engage people over these digital modalities. And I'll actually help dispel some of the myths around some of the technologies as well, as we just reduce that friction in the marketplace, make it more accessible. And I love the STS flywheel, right? Which is again about access, awareness, and trust. And we'll talk to those different points. And so at the bottom, you can see sort of the theme is just create meaningful conversations to drive action and engage communities in their health. And we'll talk about the ways that we do that in, I think, a really unique way. A couple of stats, because we always get the, well, how many people have mobile phones and how many are smartphones and can they engage in these channels? But what about underserved populations? And I think what you'll really be surprised about is that, some of the metrics that we see as we engage, and we have 65 million Americans that we're engaging today through our platform. We will probably do 500 million digital engagements in 2021 on everything from helping to close gaps in care, medication adherence, COVID related, support as we're partnering with Stop the Spread here. And so what we actually will see is obviously some stats that may surprise you and some that may not, but I'll run through a few of those. As Jim mentioned just a minute ago, the question around, multiple follow-ups and multiple touch points, which is really key. We know that, SMS actually has much higher engagement rates for underserved populations than other channels. Mobile is actually the primary access point for these consumers. And so we need to make sure that all of the content that we're creating is in that mobile friendly connected model. And so what we are really happy to see is that, there's 95% mobile phone ownership in the sector today. 79% of those are actually smartphones, which means we can deploy more rich media, videos, education, even photo novellas or image-based communications as well, which really resonates with these different segments that we're working with. The dependent access, it's about 31% that this is their primary source of engagement. And then one thing that surprises a lot of people is that the average response time, to outbound engagement is about 5 minutes over SMS. And so when we engage, if it's an engaged population, you're going to get that immediate response and relevancy, to be able to continue to drive that engagement that we're looking for. So recently, and I just pulled this in last night from part of the work that we're doing. This was based in May 1st. So just getting this sort of hot off the press for the close of last month. And in the middle of the screen, I think a few points that you'll see again through these dialogues, we're learning and we're asking open-ended questions. And I'll show you a video that shows how that works and how we actually can create these dialogues to get information back to, the communities to really understand what are those, again, perceived barriers that may exist. And so a few stats here, when you look across this was about 3,000 individuals. This particular segment was about, 39-40% that had already been vaccinated. But I'm going to focus really on the right side that we all are really working on today, which was I plan to get it as soon as possible. I plan to wait to see how it affects others. I don't plan to get it, anytime soon, but maybe in the future. And then I don't plan to get the vaccine ever, right? And so I pulled just a couple data points out that I thought were interesting and compelling, I think, to really drive the need for the work that we're all doing together, is the perceived susceptibility that 29% of people still believe they're at low risk of getting COVID, right? So that's a large part of this particular segment that says, well, that's not going to affect me, right? And so we need to sort of help articulate that, and we'll do this and I'll highlight through learning and education. 45% of those actually had fear of side effects from the vaccine. And so that's again, a large percentage that we have to tackle that particular problem and the learning strategy and behavioral strategy around it. 57% felt that the vaccine just may not protect them. And so the feedback they're telling us when we ask the question, well, why haven't you scheduled it yet? Why do you not plan to? And they go, I just don't think it works for me, right? Or, for my particular family, I don't think we need it yet. And then the accessibility is there's still 31% of the people as of this particular, engagement that actually didn't think it was available for them yet. And so as we sort of work through this, we see that there's lots of different reasons for hesitancy that we're actually building those strategies on. And so we try to do from a digital perspective is to leverage these particular, strategies in building these two-way and interactive conversations we'll show you the knowledge in the Learning Center of how we're building knowledge to really help inspire and to build confidence for these different individuals to be able to make these decisions, and then connect them back through these journeys to the resources that are available in the communities, and what everybody on this phone is really focused and so diligent in supporting. And let's connect people to the resources that exist, and that Charlotte and Molly and everybody's been working so hard to get into the markets. And then lastly is measurement of those outcomes. How many people are we helping to move through that? Are we measuring that learning journey that they're actually on as we go forward? And so what we produced was the Live Well, Vaccinate program, and the goals around that to, dispel the myths that we, saw a few on the previous slide, uncover and overcome those particular barriers, boost confidence and efficacy, obviously, build COVID-related health literacy. We know that this is not just a 2020, 2021 challenge. We're going to continue to manage this over the next, several years as we go forward. And then obviously we want to help people understand the process and how do they do it, and then get to that ultimate goal of improving vaccination rates. And so what you'll see in the video I'm going to tee up in just a minute highlights these particular learning journeys that members can go on. But just realize as you see this, these are tailored based on the responses that those members are actually stating. And so, in this particular dialogue, just engaging around particular health and checking in with someone during the Safer at Home. And so a program we did to help support social isolation. And Jane says, "Hey, not too bad. My daughter came by with groceries this afternoon." Well, that's great. We'll check in from time to time. We're building a relationship. And so these are all automated dialogues that are occurring. And then that gives us the permission space and the trust to ask those questions about, have you scheduled your vaccination yet? Can we help you coordinate that? And sort of moving through, these particular processes again, and keeping that as relevant and as engaging as possible. We bridge that back to these learning centers that we talk about, and again, using knowledge to inspire behavior change. And so again, these are tailored experiences, but allows individuals to self-navigate. So think about, TikTok or the YouTube generation. And so the ability to leverage, streaming video through this particular, mobile channel, that people can get a 30-second, a 2-minute, or dive even deeper into a particular strategy that says, are vaccines safe? What are the side effects, and really understanding these particular barriers to, again, get them over that curve, allowing them to do this at their own pace. And what you'll see is we'll mix this with expert advice of subject matter experts, but then with authentic stories from individuals and really their strategies of why vaccinate for them and for their families, that becomes more meaningful. And that's really, really what they are most focused on. And so, through these journeys, it's really us asking, the right questions. We gather a tremendous amount of data about these interactions, again, on uncovering what those barriers are, so we can tailor those. So, learning that Jane was, vaccine hesitant because of fears of side effects, understanding that somebody else has challenges with transportation or getting to those services, and then tailoring those down in communications to connect them to the right resources that are available. And so what you see here is just a little bit of that digital experience and framework through that dialogue. And you can see on the left-hand side as the person says, the question around, just curious, about, you getting the vaccination and protecting your family. And they're like, yeah, I'd like to learn more, right? And we can accept, different languages if they respond in Spanish, no entiendo, and we can shift from a language preference. Or if they send us a thumbs up emoji, great. We know that sort of permission space to, continue the dialogue. And then, these are, meant to be very conversational. And then, the person highlights the fact here that they say, well, I hear about side effects. And so then we pull that out from a natural language understanding perspective, and then can actually tailor that next snippet or video related to, safety and side effects. So it's relevant again to that particular dialogue. And then that individual can then, drive into the Learning Academy and again, self-navigate on the resources that are available to them. And then if we see that we can get them over to scheduling or another service, we'll absolutely drive through, those capabilities. So you'll see this play out in just a second through the dialogue. So last piece I'll mention, again, just a little bit of the snippet on, again, expert testimonials, Dr. Reed Tuckson as well, and others, really, I think, leaders in the space that have supported these strategies, and then voice of consumer and those resources. And the last one that you just won't see really much, but it'll go quickly in the video, is looking at assessments. And so in many cases, we'll ask those open-ended questions and go, are you feeling more confident? What other questions do you have? And again, that gives us the learning to continue these particular processes as we go forward. So with that, let me go ahead and kick this off, and we'll be able to take any questions as we go forward. So we'll make sure we get things teed up here.
Why is it so important for me to get this vaccine?
Does that mean I can stop wearing these masks and worry about social distancing?
Why should I trust anything they're telling me about all this?
We have got to break through all the noise and misinformation to help you understand the truth about COVID-19 and the vaccines that can help us in this international crisis. Welcome to Live Well, Vaccinate. My guest and I are going to explore all things COVID vaccination.
This vaccine is one of the most important things we've had in quite a while, so we don't take that lightly, and neither do we take your health.
Disparities in the Latino community is not a new thing. It's not a new problem, but COVID has extremely exacerbated it.
Herd immunity, there's really two ways to get there. One is let everyone get sick, millions of people die, or the way that we can get ourselves out of this pandemic is we vaccinate.
There's a really important role of vaccination, and that's to protect each other as a society.
Do it for yourself because you can, and do it for them because they can't.
I basically haven't worked since COVID hit.
Me voy a vacunar para que podamos terminar con esto y abrir para siempre.
I can't wait to get that vaccine and get back into the classroom.
This last year, COVID-19 has challenged each of our ability to feel in charge of much of anything. This vaccine presents an opportunity to take back control. I hope you seize it.
Why is it so important?
So, that just gives you a little bit. So thanks for the patience to run through the video, but I think it touches on so many elements and gives a bit of a mix of the learning centers and strategies that are there to tackle those different questions. And the one I love, it goes by quickly, but it says there's a whole video on why vaccinate. And then I love the one, which is vaccinates only work if you get them. And that's sort of like, I love the lottery advertising is you have to play to win, right? And so that's the strategy that we're on, is really helping consumers play to win, helping them build that education, helping them build those strategies, and then connecting back to the community resources that exist. And so through that, I think, there's a few examples that, we can send afterwards, but I think that we learn a tremendous amount from an engagement perspective about, the outcomes, the preferences, the barriers, really the intent. And so we want to pull that information back, through these dialogues and just make sure, again, that we're, connecting them to the work that's happening in the local communities. And again, supporting access is that number one factor, and digital allows us to create a much wider access, net and really safety net that we wouldn't have had before, giving them access to rich, media streaming services and education that's really at multiple levels that really meets consumers where they are from a learning journey perspective. So with that, we'll go ahead and stop, take any questions, then we can jump back over to Charlotte and Molly.
Great, thank you, Chris. And I have one question, and it relates to a question that's also in the chat, so I'll combine them. So first, and I may have missed this, but how does somebody start on the learning journey pipeline with you all? How did they get into that process? And then second, this is a question from Carlos in the Q&A. Could you talk more about the factors that determine the virtual journey that each person gets? Is it only ethnicity and vaccine confidence? Is it professional background and location? What determines where people are filtered?
Absolutely. So I'll go with the how do you start. There's two strategies predominantly that our partners leverage. One is that individuals can text in to learn more, and so through different marketing media advertising is then there's just a simple short 5-digit code where they can text in to actually get information and start the dialogue to learn more. And so those can be at vaccination sites and others. And so that's sort of the inbound. The other is through collaboration with Community Health Network that was mentioned too, and that partnership. And I think the team's done an amazing job at building that relationship and again connecting to their population. And then they can help promote that set of services and do the initial communication that we can do over SMS, over email to bring into these services and make them aware. And then that actually is what starts that learning journey. So those initial sets of just conversational questions, that almost feel like they're coming from an individual, allow us to begin that tailoring process. With some of our customers, we have a lot of rich data, because they may, we may be communicating with them around medication adherence, closing gaps in care, other clinical information, so we can tailor. Sometimes we'll have demographics. If we get zip code and others, we can do much better, CNI or local targeting of that types of content. In this case, in many, areas related to COVID and vaccination, we don't have much data at all. And so we'll build that profile based on those interactions and learning. If they highlight, for example, their language preferences, Spanish, or, highlight some other factors, we can even ask zip code, for example, if we're not getting that information, to see what services are available in those areas. And so when we can start with a good data set, we can be much more tailored. Without starting at that point, we have to ask those questions and build that dialogue to get those learnings.
Yep. Got it. Thank you.
I just wanted to add from we looked at a lot of different potential tools to try to do this work. And I think one of the things that we really like about the ability of MPulse is having this short code where people can just text in. So as Charlotte has her site directors going door to door to encourage people to come to the vaccine site down the block, but they aren't quite ready, as soon as they go to the next door, that engagement moment is gone. We can share this short code with them and allow them to get connected to something that's going to continue to answer questions for them. That felt really important to us as a part of the strategy.
Yeah,
awesome.
Yeah, absolutely. All right, for the sake of time, I'm going to save further questions until the end and turn it back over to Charlotte and Molly.
Wonderful. The last two, and thanks so much for sharing all of that, Chris. So the last 2 points that we want to hit on are our vaccination experience on site, and then our vaccine plus work as the last two of sort of the five key sort of takeaways that we want to really raise. So I'll start out by talking a little bit about vaccination experience, and this really comes from our reflection that word of mouth is critical in getting folks to trust our site, for them to be truly accessible, and for them really to be aware of the sites in the neighborhoods. So we found that the following elements are really essential to creating a positive on-site experience for folks. First, our sites are staffed by community members. So as I mentioned, they're community members on the outreach teams, but then there are actually parishioners from the church that are the on-site staff that are registering folks and guiding them through the vaccination process. We always have a doctor on site to answer questions, which is really meaningful and helpful to folks. There are translators available. We are sure that our sites are staffed with a multilingual staff, and then we make really clear from the moment of outreach and then also on site, we're never going to ask about immigration status, and insurance isn't required. One sort of case where these methods were really sort of came to life was at a Sunday supper event where we partnered with the C19 Coalition on Mother's Day. And we offered a free meal from a local restaurant and a free supply of masks along with the vaccines. And as you'll see on the page, Dr. Brittany Richards of the Greater New York Black Nurses Association was on site to answer folks' questions the day of. That Sunday supper event was a step towards, one, prioritizing creating a really welcoming, positive on-site experience for folks when they got vaccinated. It was also a step towards offering more than just vaccines at our sites. And that's the last point that I will discuss. So the last point that we wanted to talk about here are really incentives, and specifically the way that we are thinking about the intersection of incentives and equity. I know that probably everyone on this webinar have likely read all the news about all the incentives that are rolling out across the country to encourage vaccinations. And we, as you said, we are not in the position to be offering $1 million for folks to get vaccinated at the community healthcare network sites. But our question is not just how do we incentivize people to get vaccinated, but how do we actually make the incentive itself something that drives health equity and gets at needs that have been around long before the pandemic. So our approach here to incentives is something that we're calling Vaccine Plus. And we are doing this work in Los Angeles and in New York. In Los Angeles, we are doing this work with St. John's, which is a federally qualified healthcare center that is the largest healthcare provider in South and Central Los Angeles. And we are working with them to offer 4 interventions. We are enrolling in the observation period right after folks get vaccinated. We are enrolling uninsured individuals in Medi-Cal. We are connecting families to free meals. We are scheduling health exam appointments and behavioral health therapy. And we are also referring individuals to other social services. On the East Coast, we're also starting this work offering diabetes and cholesterol screening programs in partnership with Cornell Medical School. So we believe really deeply, one, that we can transform that post-vaccination observation period into a real moment of care, and that offering these equity-oriented incentives and reframing the vaccination experience is not just a moment to get vaccinated, but also a moment to really invest in health equity is core to the work that we do. So that was the last of the 5 sort of takeaways I wanted to highlight, and I'll hand it over to Molly to sort of take it from here.
Great, thanks, Charlotte. So we very much see this work as just the beginning of a much longer effort that we think needs to take place to transform the way that we do community health, and especially the role that private and public partnerships can play. If we were to just take the most fundamental metric of health equity, which is life expectancy, we see that COVID has reduced the life expectancy of people who are Black or Latino by 3 to 4 times that of people who are white in the United States. This is data from the National Academy of Sciences. And so as we find things that are working during this last and really hard mile of vaccine distribution, we believe it's important to preserve and sustain those efforts going forward. And on the next slide, you'll see, and we can share in the chat as well. At Stop the Spread, we are sharing the lessons that we've learned in an open source playbook. It includes downloadable tools for vaccine sites, 3 different types of pop-up models to consider for your community, a guide for assessing equity at vaccine sites, a discussion guide for starting conversations between health clinics and community partners and churches. We'll provide the link to the playbook in the chat, and we welcome you to contact us if you also have examples of practices that can contribute to this work. What I'll leave you with, and we can open it up to questions, is just some of the lessons that we believe need to be sustained for the long term. Just to highlight a few of these, the trust that's been built through community partners and healthcare organizations, we believe needs to be sustained. To the question earlier around sort of playbooks to do this, the reality is a lot of these CBOs know how to do this work. And we just need to tap into them from a healthcare perspective and leverage those existing communication channels. And we really see that be effective in New York. Investments need to be made with equity in mind over just access alone. We have certainly seen that people are one of the most under-leveraged resources in the work that we're doing, and we are trying to bring in community health workers, peers, friends, families, to include them and partners in this process. We think that there's a lot of opportunity for behavioral science to be a part of the health equity solution as well. Companies like Impulse are getting started doing this for us now, and we think that those sort of personalized nudges can be really powerful in encouraging everyday healthy decisions. And then finally, hyperlocal approaches that can be bolstered by public-private partnerships and scaled nationally present a huge opportunity to be able to do this work faster and do it more efficiently to better health outcomes for all. So with that, we thank you so much for the time, the discussion, and look forward to questions.
Thanks, Molly. One question that was referenced in the Q&A is where you see, you mentioned the transition from larger sites for sort of the first wave to more local sites as distribution gets a little bit more challenging, or I'm sorry, as vaccination gets a little bit more challenging. Do you see any additional changes as vaccination continues over time that you anticipate you'll be learning or that you'll be adjusting or at least anticipating as you go?
I think definitely we're starting to see changes in our approach as 12-year-olds are now available for the Pfizer vaccine, and how are we going to engage schools and sports teams or children themselves, frankly, if their parents aren't ready to be vaccinated, but maybe we can get information to them that can be influential. I think that's the next sort of big learning curve for us. I don't know, Charlotte or Chris, if there's anything you'd add to that.
Yeah, I think that agreed. And I think the only other thought is when we started the work with CHN, the pop-ups were happening in parallel, but our focus at the start was really on setting up these for fixed sites. And over time, we've just seen week by week more and more just how important these pop-ups are. And, you know, it's one thing to have the vaccines available in, you know, the Church of God in East New York, but there are folks who live 10 minutes away who that's not their church. And so they're not going to get vaccinated there. And so we've continually been pushing ourselves to scale up the pop-up work and think about how can we continue bringing more partners and getting vaccines even further and further out into the community.
Yeah, and this is Chris. The only other thing I'd add to that is I think is as it does evolve right now, bringing in sort of 12 to 18-year-old and sort of this really is just illustrating the fact that we're going to have to continue to change our engagement strategies, right? And where are these tweeners looking for information? Where are those trusted sources for them? And let's just make sure that we don't leave that behind, because that's going to be the the resources that we need to be really relevant and resonate for them.
Another question from Rachel Bridges in the Q&A. You mentioned health equity. Has there been any discussion of or use of messaging around global access to these vaccines in low and middle income countries in your outreach or materials?
Yeah, I would say so much of our work at Stop the Spread right now has been very much focused on the efforts here in the US. We are a part of a coalition called the C19 Coalition that is doing a lot of interesting work right now in India in particular. And so I would definitely encourage, if people are looking for what's happening in other countries, would really encourage checking out the C19 Coalition and their team.
And we have a hand raised in the chat, which is a first. So I'm going to see if I can allow Brooke to ask her question out loud. Brooke, you may be on mute. Okay, well, I also see that you've typed your question in the chat, so I'll try to repeat it, but let me know if you have any additions. So apologize if this question has been asked already. What do you see as the role for incentives for vaccines? I know you were just touching on this in the Vaccine Plus. So if you maybe just briefly recount that for Brooke, or any additional thoughts on incentives as part of your work.
Yeah, so I guess just to highlight what Charlotte mentioned, so we definitely see this idea of a Vaccine Plus model and getting people connected to services that can address needs that have really been exacerbated during this time as an opportunity to not only use an incentive, because I can come in and get my health screening, and I can also get I can come in and get my vaccine, and I can also get a free health screening for diabetes and a cholesterol check, all at the same time, all in that 10-minute period. They're going to get their results for their health screening, which is incredible. So we definitely see that as a way to incentivize people while also advancing health equity. I think the other piece, and I don't know if it's called an incentive, but it's just this idea of creating community experiences around vaccines. Like we mentioned, we're planning to do for Pride, and bringing people to a park in Queens for a barbecue. We're going to do HIV PrEP education while they're there, and it's going to be together and run by people who are coming out of the transgender program at this FQHC. And so really like creating a community experience, I think, is a great incentive in and of itself, or at least that's how we're starting to think about it.
Absolutely. I'm curious the degree, what the uptake or adherence or support for the additional services has been like. Have you encountered barriers? Has there been skepticism? What's the reaction been like to date?
So we actually started this work by asking the community what they needed. We actually ran surveys for almost 3 weeks at each of our churches in New York to understand, what needs they had. Anxiety, mental health, interest in healthy eating and nutrition, really interestingly, came to the top. We also see that 33% of the people coming into New York are currently uninsured. Reported 25% of them don't have a provider, and we expect that number is higher given the uninsurance rate. So we very much design the needs around the services that people are looking for. This work is just getting off the ground. We just launched in LA a couple of days ago. And so I'm sure there will be learnings as we go along, but I think we're very much intending to design these types of supports around specifically what the community is asking for. And it's optional. If someone doesn't want to have a health screening, they can just get their vaccine, and that's okay too.
If they prefer the $1 million, that's just the backup. So with that, I know we're at time, and thank you so much for taking the time to explain and communicate really what's, I think, extraordinary work that you all are doing together in New York City. So thanks everyone for joining us. We will be sending out, as always, a recording and transcript of the webinar, along with all of the slides and the supporting materials, including the playbook that Stop the Spread is releasing today. So with that, thank you everyone for joining, and we'll be in touch soon with details on the next webinar.